Thank you very much. It is my great honor to talk to you today about this study with the title Venetoclax Monotherapy Induces Deep Remissions, including complete remissions in undetectable MRD in ultra-high-risk relapsed refractory chronic lymphocytic leukemia with the 17p deletion. Importantly, these are the results from an international registration study in this population. Now, as compared to the previous two talks on chronic lymphocytic leukemia, this is a very special population with the most dismal outcome that we have today. These patients had not only relapsed on conventional treatment, but they were homogeneously defined by the presence of the 17p deletion, which destroys the TP53 tumor suppressor gene, and therefore these patients are resistant to conventional therapy. Now, Venetoclax is an agent targeting a key biological phenomenon of the CLL cells, namely BCL2. BCL2 is highly expressed in all CLL cells and is a regulator of apoptosis. Now, with this agent, we can drive cells into cell death or apoptosis, irrespective of genetic features such as the p53 abnormality. A phase 1 first-in-human study of this agent reported in an unselect relapsed refractory patient population with CLL a 79% response rate. The results of this study, as I said, are the data from the international pivotal phase 2 trial of this agent in a homogeneously defined patient population, all carrying the 17p deletion. The objectives of the study, the primary endpoint was the overall response rate as determined by an independent review committee. Secondary endpoints were the usual time-dependent endpoints and safety variables. Main inclusion criteria, as I said, all patients had to have relapsed refractory disease and all with confirmed 17p deletion by central laboratory assessment. Main exclusion criteria were prior allogeneic stem cell transplantation and Richter's transformation. Now, because this agent has been shown to induce very rapid onset, very deep remissions, even in high-risk CLL, there's a concern regarding tumor lysis syndrome, so a rapid destruction of these tumor cells leading to debris of the cells potentially doing harm. Therefore, a stepwise ramp-up dosing of this agent was introduced in this trial, and the starting dose was actually 20 milligrams, which is only 5% of the target dose of 400 milligrams to be used with this agent. And with these 5% dose to begin with, in my personal experience and also shown in this trial, you see already destruction of tumor cells. And this is highlighting the dramatic efficacy of this agent, because I'm not aware of other chemotherapeutic or therapeutic agents in general that when used at a 5% of the target dose are able already to achieve tumor cell reductions to a significant extent. This table summarizes for you the primary endpoint of the trial, response. In the middle column, you see the independent review committee determined a response rate. The overall response rate was a remarkable number of 79.4%, and importantly, a number of patients even achieved complete remission or complete remission with incomplete recovery of their counts, a sign of dramatic disease reduction. Now, the results are best illustrated to me by this plot that illustrates the change in peripheral blood lymphocyte count in these patients. The top end of the bar with a black dot always reflects the baseline white cell count or leukemia cell count in the blood of these patients, and the lower end of the bar, the white dot, indicates the best achieved response. Now, it is remarkable to see here, when you focus on the left of this graph, that some patients entered this trial with 200,000, 300,000, 400,000 white cells. And even more remarkably, you see when you focus at the lower end that virtually among almost all patients, actually except only 4, there was a normalization of the lymphocyte count to the threshold, the usual threshold of less than 4. So dramatic disease reduction in the blood as an evidence of the efficacy of this agent. And importantly, the median time to normalization of the blood count was only 22 days, so just over 3 weeks. Now, another way to look at the result is given in this slide. This is the cumulative incidence of response. On the left, in the blue curve, you see the overall response, which is, again, very rapid in onset. Median time to first response was 0.8 months. Median time to complete response was longer, and as the follow-up of the trial is still relatively short, probably these responses, these complete responses, are evolving over time. On the right, you see the analysis for the minimal residual disease, so by very sensitive molecular techniques, characterization if in the blood of these patients still CLL cells were detectable. And you see in the blue curve here that quite in a proportion of all patients, 18 of 45 patients tested, there was absence of minimal residual disease. The green curve looks at the patients with a complete clinical response only, and you see that the rate in these patients, not unexpectedly, was even higher. This slide gives an overview of the adverse events. Neutropenia, grade 3-4, when you focus on the right column here, was observed in 40% of patients. This is a number that you usually see, has previously been introduced to you already with chemotherapy in the frontline patient population. So it is not surprising that in these patients with heavy prior therapy, we see this rate. However, it is reassuring that infections were uncommon. The most common infection were upper respiratory tract infection at the very bottom of the table. And overall, the grade 3-4 infection rate was 21% only, which is actually lower than with frontline chemoimmunotherapy regimens such as FCR. Now, in conclusion, Venetoclax monotherapy achieved very deep responses. There was a greater than 10% IRC confirmed rate of very deep responses, CR, CRI, or nodular PR, and of note, MRD negativity was achieved in more than 20% of responders. Moreover, Venetoclax showed a favorable risk-benefit profile. The risk of a clinically relevant tumor lysis syndrome was efficiently mitigated with appropriate measures in this trial. Neutropenia and infections were actually lower than expected in this high-risk population. And based on these data, I think there is a very positive prospect to incorporate Venetoclax as an attractive component into novel combinations or sequence in patients with this very high-risk disease characterized by 17p deletion. Thank you very much.